Hey everybody, Will Martin. Welcome to the Nurse Scientist channel. In this video, we're going to talk a little bit about a 38-year-old nurse by the name of Redonda Vaught, who was an RN working at Vanderbilt University in 2017 when she committed a medication error, and now she's standing trial. So the general background of the story is a patient was getting ready to go in for a procedure, I believe it was an MRI, and needed to be sedated partially. As we know, when you put somebody in the tube, oftentimes they're claustrophobic and they have to lay perfectly still in an MRI. So it makes sense if this was an MRI that the patient was going to undergo, she probably needed some sedation. So this nurse, Redonda, was intending to give Versed, but instead gave vecuronium. And this was an error that was partially committed by overriding the Pyxis or whatever other medication dispensing system they're using there. And she mistakenly chose the wrong medication to give. Now, as you know, Versed is a benzodiazepine and vecuronium is a paralytic agent. And apparently, after giving the wrong medication, she failed to realize that the patient was paralyzed, and ultimately the patient died. Now, she admitted to the Tennessee Board of Nursing last year that she was complacent and that she was distracted, and primarily was distracted by a trainee. Now, according to news reports, she owned up to the error right away, but she said that the error was not hers alone. Now, normally in cases like this, as she did last year, she went before the Tennessee Board of Nursing. She probably would have lost her license, and that would have been the end of her career. Instead, this week she's going on trial for reckless homicide and felony abuse of an impaired adult. Now, if she's convicted of reckless homicide, she faces 12 years in prison. Now, prosecutors don't allege that Redonda intended to hurt the patient or that she was impaired by any drugs or alcohol. And what makes this case so rare is that typically these things are handled by state boards of nursing and maybe civil court. Now, some news reports indicate that Redonda overrode the Pyxis and circumvented the typical procedure to obtain medication from the Pyxis. Those of you that work with Pyxis or Omnicell or any other type machine that I've worked with in the past know that oftentimes you have to override because maybe there's an emergency use or emergency need for a drug, and the provider doesn't have time to enter the order in the computer, so the nurse is going to override that in order to get that medication out of the drawer. In this case, what it sounds like is that she typed in the first 2 or 3 letters for Versed, V-E-R, and didn't find it because it was actually listed under midazolam, which is the generic word for Versed. It sounds like she became frustrated and wound up pulling out a medication that sounded similar, vecuronium. Now, it's been a long time since I've handled vecuronium myself. I've certainly had it administered on somebody that I'm ready to intubate, but I haven't drawn it up in a while. But from what I can see, that these bottles are clearly labeled as a paralytic agent, and that just the fact that the bottle was marked as such shows another misstep in the process of ensuring the right drug, not to mention the right dose and the right route and everything else. Prosecutors are alleging that this wasn't just an average run-of-the-mill mistake, but that she was so egregious in ignoring a cascade of warnings that any other prudent nurse probably would have seen before administering the drug. Documents seem to indicate that she bypassed at least 5 warnings on the Pyxis and also pulled a medication, vecuronium, that comes as a powder and needed to be reconstituted, where if you're familiar with Versed or midazolam, that comes as a liquid in the vial. The defense's argument is that the vecuronium should not have been as easy to access. So as this trial gets underway, we're all going to be watching it closely to see what happens. And it certainly has ramifications for all of us that administer medications. None of us want to make an error. None of us want to harm anyone, but we're human beings. And as I've said to patients in the past, being admitted to the hospital is not a benign event. There have certainly been cases recently where I've advised patients that maybe if they could be taken care of at home, if they had family available, and if they weren't alone, maybe it would be better to be discharged home and follow up closely with your PCP than be admitted to the hospital, particularly in the case of COVID. When we had so many COVID cases in the hospital, and if this patient was negative for COVID, I felt that the risk of becoming infected with COVID by being admitted to the hospital might pose a greater risk than being discharged home with close follow-up. I've also said to some patients in the past that maybe we're on the fence about being admitted to the hospital or not, that coming into the hospital is not a benign event, and that your care will be in the hands of several human beings, and that error can occur. Now, this isn't a routine statement that I tell everyone, but it is true, and it is something to take into consideration when you have a patient that isn't really a clear admission case, and maybe you're on the fence about whether to admit versus discharge home. These are things that I take into consideration, and these are things that I discuss with the patient. Now, I'm sure if you're honest with yourself, you'll probably realize that at some point in your career, or even as a student, you've probably made an error or come close. You've had a near miss. And I can tell you that my first job as an RN was working in cardiopulmonary ICU. And at that time, this was back in 1990 to 96, we had a med cart at every bedside. And that med cart contained every drug that we were likely to use on that patient. Everything from antibiotics that needed to be reconstituted to other vasoactive medications, because we mixed our own drips. We gave our own potassium. And that was one thing that was eventually fixed, was the similarity between the potassium chloride vial and a normal saline vial for a flush. They came in the exact same plastic vial, but were just two different colors. Now, I never made an error in that regard, but you have to wonder, since those vials were distributed across the world, how many patients got a bolus of potassium chloride instead of normal saline to flush their HEP lock? Today, it seems that pharmacists, at least in my hospital, pharmacists mix all of the medications, including all of the vasoactive drips that we do, the insulin drips, everything. But not that long ago, it was the nurse at the bedside that mixed all of those medications and hung them. We've come a long way in that regard, but even back then, in the early 90s, we were using a Pyxis type system. And certainly, there were times where you had to override it because you needed a medication. Maybe you couldn't remember the patient's name, but you knew the medication that you needed to give. And so you did an override to get that medication out of the drawer and realized, well, at some point later in the shift, I'll go back and put the patient's name in and, have it all correct. These things happen, especially when you're busy, especially when you have a short staff situation, which it seems as though we're in every day now. And certainly if you're orienting or training someone, you're distracted by that also. So this is a case that we should watch closely, because if she winds up being sent to prison for this, it just illustrates how important medication administration is. I often think about the airline industry and how the airline industry, when the pilots are in the cockpit and the door is closed and they have what's called sterile cockpit, then there is no discussion going on except discussion directly related to that flight. And they have checklists, and they go down through the checklist every single time as they're taxiing out of the gate, as they're doing their run-up. They're having checklists, and they've been through these same checklists hundreds or thousands of times, but they do it every single time. And I think in a lot of ways, medicine and nursing should take a cue from the airline industry and institute checklists. It's not defeatist to say that we should create and abide by checklists. For example, if someone comes in heart failure, there are certain things that are going to be done for that patient in heart failure every single time. There are certain lab tests that we're going to do every single time. EKG is going to be done every single time, a chest x-ray, probably a pro-BNP. I mean, you know the drill. But if you're not going by checklists, there's a good chance that at some point you're going to leave one of those tests off, or you're going to forget to do it. And you're going to work a patient up, and then you're suddenly going to realize an hour after they're there, oh, I never ordered a chest x-ray. These things happen. Is it the same as a medication error? Well, you can argue. It depends. I mean, if you don't do a chest x-ray on somebody who's in heart failure, who has pulmonary edema, and they're breathless, and you haven't made that diagnosis of pulmonary edema, and you haven't given a diuretic to that patient, well, that's right along the same lines as a medication error in my mind. So the moral of the story is be careful, be thoughtful, pay attention. If you're in school, when you're being taught medication administration, you're being taught a procedure, you're being taught an algorithm for a reason. And it's something that you should do every single time. Let's face it, we're in a business that is supposed to be zero mistakes. And I think that's what's so stressful for all of us, certainly for me, that when I go into work, I know that this is a zero mistake business. Does it mean that mistakes won't occur? Probably a mistake will happen, but you have to approach this as a zero mistake business. That's why it's not for everybody. Not everybody can do our job, your job. If it was easy, everyone would be doing it. So I hope in discussing this, you'll track this case and keep an eye on what the ultimate verdict is. I know I will. And it's a great reminder to be extremely careful with what you're doing. Limit those distractions. Be prepared. Be well rested. And always keep your eye on the patient. Well, I appreciate you listening to me. And I know that I haven't been able to make a video here in about a week. And that's mainly because I'm the lone survivor of a COVID super spreader event that occurred a little over a week ago. One of our PAs had a 40th birthday party, and she invited her family and friends and coworkers from other hospitals that she had worked at. So there were probably 50 or 60 people at this birthday party. And apparently someone in her family had symptoms of COVID, didn't necessarily recognize that it was COVID because it was relatively mild symptoms, but wound up infecting about 20 people. And several of those were nurses that work in the emergency department with me. So over the following several days, as one by one people started becoming ill and testing positive for COVID, they're out of work for at least 5 days. And that included one of our PAs who actually is undergoing chemotherapy right now for prostate cancer. So in his case, he's doing okay, but it gets a little more serious when you're immunocompromised, obviously. But for whatever reason, I never got it. I never had symptoms. And for that matter, I've never tested positive. And I have been exposed to COVID, as probably a lot of you have. I've been exposed hundreds of times. And I've been PCR tested many times, and I've never turned a positive test. I even had symptoms back in early January that I thought, okay, I finally got it. This is it. I've got a really sore, scratchy throat, and I hardly ever get a sore throat. And I had a cough, and I was really very fatigued, but I tested negative. So it makes you wonder, if you've been practicing for 30 plus years and you've been exposed to coronaviruses for all of those years, is there some immunity obtained as a result of that exposure to other coronaviruses? I haven't seen anything in the literature about that yet, but it's interesting. So that's it for now. I'm going to work on some other videos here soon. I'm afraid that there's probably going to be another long stretch of work, but I'm going to try to keep things moving along on this channel as best I can. Please, if you can, subscribe to the channel. That helps to move things along for me, and it helps to make the channel grow. And if you can leave a comment, I appreciate that. I really enjoy reading all your comments, and I try to respond to everybody if possible. So for now, I'll say thank you, and I'll talk to you again soon.